Welcome to another episode of the MEGIN Spotlight series. We are delighted to have Simon Vogrin, a clinical multimodal neuroimaging scientist from St Vincent Hospital, Melbourne, as a guest today. Simon has over 20 years' experience in clinical neurosciences, spanning both standard neurodiagnostic techniques and the translation of clinical research approaches to routine practice. We also welcome Professor Chris Plummer, a practicing neurologist specializing in epilepsy over the past 2 decades, and he's recognized as an international expert for the clinical application of source analysis. Both Simon and Chris are also managing directors and co-founders of EMSL, a privately run centre in Melbourne. The facility utilizes MEG in collaboration with Swinburne University of Technology. Thank you both for joining us today, Simon and Chris. So let's start with the first question to Chris. How did you first hear and learn about MEG technology, and why do you utilize MEG in epilepsy patients' care plans?
Well, I've known about MEG and MSI since my early days learning how to do EEG source imaging 20 years ago now for my PhD. And I was very fortunate to have had the chance to apply similar principles to MEG in about 2013 for my postdoc at Swinburne University of Technology here in Melbourne. And as luck would have it, a MEG unit had not long been installed at Swinburne's neuroimaging facility. So over the last 10 or so years, I've become absolutely convinced that MEG offers enormous untapped insight into the localization of spikes, seizures, epileptic rhythms in patients with severe epilepsy who are potential surgical candidates. It does this because I think MEG genuinely gives a window onto the brain in real time as we try to tease apart the millisecond order spread of signals as they commence during a seizure or even a spike discharge. And MEG allows us to look through this window in a very safe way, as the scanning is totally non-invasive.
Thank you. So Simon, why do you believe MEG is a vital piece in the multimodal neuroimaging environment of a clinical setting?
Well, MEG has always held a bit of a fascination, for looking at brain activity because of its elegance as an independent measure of that against EEG at the same temporal resolution. But, the seemingly inexhaustible variations we get with many pathologies in epilepsy was what really showed that with all the different modalities that are available, again, the MEG does really offer that very unique window compared to MRI and PET and SPECT at the individual patient level. And it's the very rapid changes, I think, in this non-invasive modality that's its real power, and I think why it offers a significant piece of a larger puzzle when solving focal epilepsy.
So, Chris, I mentioned EMSL earlier, so maybe explain to our audience the concept of EMSL and why the centre was established.
So EMSL, which stands for EEG, MEG, source localization, was established as a means of offering epilepsy patients a way to access MEG technology in an environment where research funding is super competitive and difficult to gain in Australia. So this means that a lot of worthy research projects don't really see the light of day. This is where EMSL comes in, where patients and referring hospitals can pay for the scanning in a fee-for-service model. And we've also negotiated a fairly mutually beneficial agreement with Swinburne University to run an affordable service. So we've found that patients, carers and referring hospitals are generally happy to pay for the service. That offers renewed insight into the nature of their loved ones or patients' epilepsy. And we've had many instances where our results have given patients a second chance at leading a normal life with successful surgery.
You're also one of the only neurologists in Australia that incorporates MEG and in your patients' workups. Can you elaborate a little bit on the detail of how MEG technology is incorporated in the treatment plan of your patients?
Yeah, so the beauty of MEG and the reason why it offers such a clear window view of the brain is that these spike and seizure fields are enormously complex. And with EEG, there is the added problem of distortion of the signal through the bony skull interface. And so because the signals obtained by MEG are so much cleaner, it allows the epilepsy specialist to more confidently see how the signal is commencing and spreading across the brain. And the key we've found with our research is it's very important to target the early phase activity of this seizure signal, or even a spike signal, so that the surgeon and the treating team are allowed the clearest view of the signal onset pattern before propagation occurs. And this is critical in allowing careful placement of any further workup by way of stereo EEG electrodes. And so it's only with precision in this non-invasive modality, real-time scanning, that we're able to help these patients out.
Now, question to both of you now, I guess, is in your view, MEG technology makes a difference to epilepsy. And can you share any specific cases that would illustrate how MEG was vital in the diagnostic process and outcome changed for the patient? We often hear about patients not being considered surgical candidates when later having an MEG has changed this. Have you had that experience too?
Well, yes, we've had a couple of cases. One particular case was recently, we were fortunate to have it broadcast on the national news, and it was a lady who was denied surgery originally for a fairly complex form of epilepsy, where she had multiple potential lesions in the brain that were possibly epileptogenic. And with our MEG recording, we were able to identify the precise lesion that was the culprit in the generation of her severe seizures. You know, a lesion amongst dozens and dozens of lesions. And it was only with the resection of the specific lesion that she was rendered seizure-free after essentially being housebound for many years due to the severity of her seizures.
That's amazing. We hear quite a few of these stories now and again. We've uncovered them over time, so it's amazing to hear that. Simon, does MEG technology assist in any planned research projects at EMSL? Are you able to disclose some that you're working on and share any projects or collaborations?
Yeah, I think, you know, the main focus of EMSL has really been about providing that that offering to patients that otherwise we don't have the luxury of these technologies available in our routine hospitals. But I guess in addition to this, we've really been striving to address many of the technical limitations that are associated with more holistic diagnosis in focal epilepsy treatments. And so we've kind of veered a little bit further away from just the traditional novel algorithms and trying to find, you know, something that's of interest to the pure scientific community. We're just trying to really refine our techniques and getting more robust clinical data. And so, you know, we're really trying to keep, you know, the personalized medicine, if you like. But the primary aim with our colleagues at Swinburne has been trying to constrain as much control over the whole acquisition process and getting that abnormal activity from patients across different modalities in the same session, which often in the clinical environment can happen over days or weeks apart, you know, especially because of complex booking schedules and the like. As I said, we've been doing this with a combined EEG, high-density EEG cap that we've been working with another local company, Copymedics, and they've been able to assist us in developing materials that are suitable for both the MEG and the MRI environment. And while there are other caps out there that have been shown to work, you know, independently, these are really the first time that we've been able to kind of sequentially record straight from the MEG directly into the MRI without moving the cap or reapplying anything. And it's given us a lot more amazing insights, and it's really kind of stimulated a lot of conversation with other collaborators. So we thought that we'll stick with the more basic fundamentals and see where that leads us. But I think the opportunities that it's opening up are really quite remarkable. So, one of the areas is that we've been looking at how non-invasive virtual sensors could be used as a better predictor, and then comparing that against implanted electrodes. But again, combining that with things like variance in functional MRI analysis and structural techniques to give us lots of different ways of comparing and contrasting whereabouts the predicted seizure region is. And the biggest problem has been, what is the extent of the resection that we're really aiming for? So all of the different modalities, I think, are going to give us a much deeper insight into what these kinds of joint probabilities of where those margins could be. So that's what we find is really exciting. We're trying to be really contained and be very careful step by step and not try to jump into too much novelty off the bat, I feel like.
Thank you. So we've come to the end of our segment today. I really appreciate that you've taken the time out to do this with us. It's been really informative for our audience, and it's always an honor for us to be able to share the insights into MEG utilization and highlight your efforts in Australia. So all the way in Australia, which is great news. To communicate this with the wider MEG audience for us globally is exactly that what we're aiming with these spotlights. So thanks again for your support and your time today. I really appreciate it.
Thank you very much.
Thank you.
Thanks so much.